In 1984, Gail Stevens, a founder and one of the intellectual giants of the specialty of family medicine, organized a conference in Keystone, Colorado to review the philosophy, purpose, and meaning of family medicine 15 years after the formal founding of the discipline. His original idea gave birth to a series of conferences over the next 30 years that would continue that process. The American Board of Family Medicine Foundation honored the memory of Dr. Stevens by creating the G. Gail Stevens Keystone Conference Series. And in June of 2015, the inaugural event in this series, Keystone 4, was hosted in Keystone, Colorado. This three-day conference brought together family physicians, other primary care health professionals, patients and community advocates, and continued the structure of an intergenerational conversation that Dr. Stevens employed 30 years earlier at his first Keystone Conference. The four major themes at the conference were history, relationships, place, and time. But the conference's chief purpose was to address the vision and challenges of being a personal physician in the 21st century through a series of questions. This brief excerpt from the conference focuses on the question, how do we create meaningful relationships with patients in a healthcare environment that is putting increasing emphasis on technology? The internet could be very useful as a force multiplier. It provides an opportunity for clinicians and teams to meet patients where they are and to meet their needs efficiently and effectively. Provides an opportunity to provide virtual visits as well as group visits online that can be very effective for both the providers and for the patients.
Certainly traditional healthcare has depended so much on face-to-face visits with your clinician and an occasional phone call, an occasional home visit. How can we make appropriate use of new and emerging technologies to provide, and the challenge, to provide excellent clinical care in a very new and different environment, while at the same time maintaining whatever we think is still important about relationship.
And so one of the difficulties that is occurring is that we don't feel as valued, in the relationship, and that some of that is a time element, some of it is the forced transactional nature of it as compared to how are you and what's happening. That seems hard to get in there the same way we used to when in front of us is they haven't had their mammogram, they haven't had their colonoscopy, and they're there and their temp is 102 or whatever it may be that is being force-fed through the system. As Jennifer said, I love that I can email my patients, they can email me, it helps the relationship. So the pluses and minuses of what's happening in tech and the fear that has for us.
I tend to give out my email to certain groups of people, like pregnant women, first-time parents, because they tend to be the most anxiety-prone patients that I have. And patients will email me and say, I have tried, calling your clinic and no one's called me back, and, or tried emailing. And I can answer in 30 seconds and reduce their fear or say, you know what, you need to take your kid to the ER. But I'm discouraged from doing that. And even in terms of electronic records, we don't have an easy way to put my email correspondent into the records. Structurally, it just makes it hard to have some of that communication.
We had this brilliant idea that if there were patients that were doing unexpected things, the community health workers were able to contact us via email, and then we could send suggestions or instructions back down. And we thought, oh, this is great. This is telemedicine. This is working. This will work really well. But then we, after a while, asked the patients, well, how does this work for you? And as it turns out, the patients felt that even though they might get the same instructions, they still wanted to see somebody. They still wanted to see somebody face to face.
Because of the disparity in interoperability amongst electronic health record platforms, we have lots of opportunities for harm to patients because of the mobility of our patients and the immobility of their data. I think it would be very important for us to continue as a discipline to have conversations around interoperability so that patients can be in different places, different locations, and be able to share their medical information within the bounds of certain privacy protections that will need to be there so that they can get care as good as the animals in our country can get care, which is very straightforward and easy to do.
It's also what consumers want, and I think it's what many of us as doctors want, which is a technology platform that is a longitudinal record of a person's health, not just their health care, that tells their story no matter which place or location they are, and where whether they're receiving care from the retail pharmacy or from their integrated delivery system, because by the way, they're going to use everything available to them. That's what we do.
The child who was very, very sick, the family was tweeting, and all of a sudden there was feedback from people who were not involved with the care of the child, wondering why in the world aren't you doing this, that, or the other, which brought home the point, I think, that while this technology can be very, very useful, I think Glenn's message that we need to be intimately involved in shaping not only how it evolves, but more importantly, how it is used is critically important.